All right, so this is very informal, so feel free to interrupt with questions related to what we're talking about or other things at any time. I'm an orthopedic surgeon, so we do surgery on joints and bones and things like that. Like for instance tonight we've got somebody with a broken hip and a broken shoulder we've got to fix, but we do total joint replacements. We did shoulder scopes this morning. So we take care of the musculoskeletal system. Today our main focus is kind of joint replacements, especially hips and knees. And the reason we have classes like this is because a lot of times it's easier to come to kind of like a group setting where you don't have to have an appointment about one specific thing and just kind of get some general information and see what would be most appropriate for you. So if you have any questions, just interrupt and let me know. What we're talking about is arthritis, okay? So what is arthritis? Arthritis is just where your joints over time have started to wear, okay? And what are the symptoms of it? Well, the main symptoms of arthritis are pain and stiffness and a lot of times swelling. And usually when somebody's got an arthritic process going on, the symptoms are worse first thing when you get up. So if you've been sitting for a while or driving the car, when you first get up and start getting moving, those first several steps tend to be the most painful. And then as you keep going, you tend to be able to walk a little bit better, but then as the day goes on, the symptoms tend to get worse again. And then a lot of times when you get back home in the evening, the joints are sore and swollen and aching. So if somebody has these things, what do? We usually have you come in and you see us in the office. We'll examine you, take a good history to find out where it hurts, what makes it hurt, what makes it better, what makes it worse, and then kind of go over things that you may have already tried. We take x-rays because x-rays are the way for us to know kind of what the joint looks like. And what you tend to see on x-rays is the joints start to narrow. They lose their cartilage space just like the tires on your car wear out over time. And if somebody's got arthritis in their knee, and we get an x-ray that shows arthritis, things that we talk to you about a lot of times are things like some exercise type program for it. We work a lot with therapists here at Shelby because they are joined in with the YMCA to do pool type exercise and pool type therapy, and that works very good for people with hip and knee arthritic pain. We do anti-inflammatories, things like ibuprofen, Advil, Aleve, or prescription sort of medications like Mobic. We always kind of check with your medical doctor though on that to make sure you don't have stomach problems or kidney problems, things like that. And then a lot of times we'll talk to you about trying an injection. And one of the first things that we usually try is a cortisone shot. What does that do? Cortisone is basically an anti-inflammatory. We add some numbing medicine to it. And it's not going to make new cartilage or anything like that, but it can decrease the irritation that's going on in the joint. And a lot of times patients, especially with kind of early to moderate arthritis, can get several months of relief with that. And then if that's not effective, we sometimes talk to you about hyaluronic acid injections. You may have had a friend that said that they got a chicken shot or a rooster shot. It sounds scary, it's called hyaluronic acid, but it's actually something found in normal knees. So if we had a 18-year-old person and we drew fluid out of their knee and sent it to a research lab, they would find this inside their knee. But then as we get arthritis in our body, the body doesn't tend to make as much of that, and we can kind of put that back in the knee. And that can help decrease pain and improve motion. That tends to work best with people with kind of early to moderate arthritis. If it's more kind of bone-on-bone arthritis, the cortisone injection usually is more effective when it's more severe arthritis. If these things don't work and your x-rays show significant arthritis, then a lot of times we'll talk to you about joint replacement. And I brought some examples to show you here in just a minute. But what is a joint replacement? We're basically going in surgically and replacing the ends of the bone so that way you get a nice smooth surface. For instance, if we look at a knee, and I've got a knee right here, so the white stuff is your own bone. These things right here are your ligaments. They're just shown as little ropes here just for demonstration. But if somebody's got arthritis, the end of the bones actually look kind of like the surface of the moon. You see pits and crevices like you see on TV when they show a telescopic image of the moon. So you see these pits and crevices, and in a lot of patients they've even started to wear into the actual bone. And so the way I talk to people about knee arthritis, I said it almost looks like if you're driving on a dirt road and you can kind of feel how the dirt road gets the crevices in it, and you feel the car kind of pulling in and out of the grooves on the dirt road. That's kind of what your knee does when you get arthritis to that degree. So how surgery works for this is we basically go in and just replace the very ends of the bone. And the goal of this is to have a nice smooth surface that articulates with a nice smooth surface. And so how do we do this? Well, first thing you do is you see us in the office, and we would try everything other than surgery first, because we always kind of view surgery as kind of a last resort. And patients sometimes will ask me, like, how do I know that it's time to have my hip or my knee replaced? And I tell them that usually you will tell me when it's time, because we will have done everything else, and you'll say, hey, that's not working, and you're having things where it's affecting the quality of your life. So can you go to your grandkid's soccer game? Does your medical doctor tell you need to walk for exercise and you can't do that anymore? Is the dog getting tired because it's not getting walked enough? You know, if you can't do the things that you enjoy doing, that's when you'll know it's time to proceed, okay? And so once we have made the decision to proceed, we talk to your family doctor, or if you have a cardiologist, your cardiologist as well, and make sure that everything is okay from a medical standpoint. And then we bring you in to meet Kim, and she kind of shows you how it works on the day of surgery. And we draw laboratory studies, make sure blood counts are good, make sure kidney function's good, so that way we don't have any surprises on the day of surgery, hopefully. And at that time, we're basically trying to minimize all the risks. So we're looking at laboratory studies. We actually now even swab your nose before surgery to check for any sort of bacteria that are there, because we have medicine we can use to treat that decrease infection rate by 50%. So all these things are things we're doing to try to make surgery as safe as it can be. But then ultimately, if we decide to proceed with surgery and you go through the joint class, then we bring you in on the day of surgery, and you meet the anesthesia doctor, and then I'll come by, or whoever the orthopedic surgeon is will come by, and we'll say, hey, is this the knee that we're doing today, or is this the hip that we're doing, and we sign it. And then the anesthesia doctors, especially with knees, are now doing what are called blocks for patients. And what is a block? A block is where they put numbing medicine around the nerves in the leg, so that when you wake up after anesthetic, your leg is numb, so that's good for pain control after surgery. And we've been doing that for about 2.5 years or so, and the patients have really liked that. And so then for a knee replacement, we would proceed to the operating room, and basically everything is kind of set up to try to recreate the anatomy like it used to be years and years ago. So we make an incision on the front of the knee, right through here, and we have a little guide. And the guide lets us, usually when somebody has knee arthritis, there's one part of the joint that's worn more than the other. And so the knee, there's kind of bow-legged or knock-kneed. And so we have a little guide that straightens that back out. And we remove just the very top layer of bone there, about 4 millimeters of bone, so about that much bone. And then replace that with metal. And then the same thing on the femur, so the thigh bone side. So there's a little guide that makes little cuts to remove all the bone spurs. And then we put the metal in, and then there's plastic in between. And this piece of plastic is perfectly contoured to that piece of metal, so that way it glides smoothly. Hip replacement is very similar. This is showing you what a hip is. Now, in this model, the clear stuff is your bone. So you can see the bone, and it's clear so you can just see what's going on the inside. So with the hip, your ball and socket has kind of worn out in the hip. And so usually with hip pain, usually people who complain of hip pain have one of 3 types of pain. One is pain just kind of in the front of the hip, right through there, and that's most likely to be hip arthritis. So if you've got pain right in the front of the groin that kind of goes down to the front of the thigh, that's most likely to be hip arthritis. Occasionally with hip arthritis, you can have pain on the side of the hip, but a lot of times with that sort of pain, it's more of a bursitis. Bursitis means where the muscle attaches to the bone, there's inflammation. If people have a lot of pain in the back side of the hip back here, a lot of times that's something going on with the back that's kind of referred down into the buttock area. And some patients will say, well, I don't even have back pain, how could it be my back? You may not have back pain, but you can have nerve pain where it comes down into your leg. And so, but if we decide that you've had some bad hip arthritis, and when we're examining you, we can tell it's the hip and not the back, then we can talk about doing a total hip replacement. It's very similar to a knee replacement. The idea on the hip, when you get arthritis, if you've got a ball and a socket, it gets to be very stiff, so that ball just won't move inside the socket. It's kind of like having a square peg in a round hole, so it just won't move. And so you walk with a stiff leg gait, and you feel pain in the groin and the side of the hip that goes down in towards the knee. And so with surgery, all you're doing is you're removing the ball and putting a new ball on in a new socket. So if you've ever broken a chicken bone in half, it's hard on the outside and soft on the inside. So with the hip replacement, what you do, we remove that ball, and so we can see the soft bone on the inside, and we put a metal stem that goes inside the thigh bone there. And that's perfectly sized to you. And it's a little bit hard to see. We can pass this stuff around just a little bit, but if you look closely up top here, there's a gritty surface on the metal, and that surface is actually a 3-dimensional matrix. It's like a maze, and the bone likes that. So it grows inside the maze and attaches onto that, and that's what keeps the implant into the bone. And usually within 6 weeks or so, the bone is grown into the implant, and that means that you have a solid fix. Then the same thing on the socket. So if we look at the socket, with the socket, it has that same gritty surface on it right through here. And so we have a little device that removes the spur, so it makes what we call a cylinder, basically like a little spherical area. And then the cup, this little metal piece right here, fits in there. And if you look closely, you can see there's little screw holes. And usually we put one screw in the screw hole there to hold it into place for the first 6 weeks while the bone is growing into that area. And then how does it all fit together? Well, with a hip replacement, you've got a ball and the socket. So we've got this ball here in that socket, and you can see there's a plastic liner. So just like the artificial knee has a piece of plastic right here, so does the hip. And so that fits right in there like that, and that lets you move your hip around, okay? Yes, ma'am?
On your diagram there that you're doing, where's the trochanter?
So this is the trochanter right here. So when the trochanter is what you can feel when you push on the side of your hip right there. And so if somebody has bursitis of their hip, it's pain right at the tip of the trochanter in that area.
Well, how common is it to break that?
How comes it to break the hip?
Yeah, to that trochanter.
So you're talking about if somebody were to fall or something like that? So there's several different types of hip fractures that you see. The most common thing that you see is a fracture kind of right here in the neck area, and that's what we see most common. You can break the trochanter. The most common thing to see is what's called an intertrochanteric fracture. So that's where the hip breaks down in this area through there. If the hip breaks in this area through here, and we're not talking about during a joint replacement, but just in general, you can put a rod in there and fix that. That's what we're going to do for somebody later on tonight. Now, some people can break just the greater trochanter off, where this comes off. The greater trochanter is the muscle that lets you do this. The muscle attaches there that lets you bring your leg to the side.
It's actually bone, right?
Right, exactly. But the muscle attaches onto there. So if you break that, then it can pull that piece of muscle off there. Most fractures of the greater trochanter can be treated without surgery. If it displaces significantly, then you can go in and fix that. The limitation you would have if that had broken but didn't heal was that people would have difficulty doing this, but that muscle also prevents you from waddling when you walk. So if that is broken in that area, then people would walk kind of like this because the muscle wouldn't be firing.
So does it heal on its own?
If it's lined up, so if it's kind of broken but not pulled apart, then it typically will heal on its own. If it's significantly distracted, you can go in and fix it with a plate and screws in that area. So yeah, but that area is just right here. And the trochanter, when you feel it, that's that spot right there on the side of your hip. So kind of going back to talking about hip replacements, we talked about how the ball kind of articulates with the socket. And this is the ball, this is the socket right here. This has a plastic liner. And you probably saw on TV like 5, 6, 7 years ago, did you have a metal on metal hip? So some people have questions about that. So what were they referring to? Well, so the one thing, when you have a ball and a socket, this part right here is plastic. So over time, just like the tire on your car, that plastic can wear. And so they said, well, what if we made this be metal and this be metal and have it just be a metal on metal articulation? They have things called joint simulators. So if you design a brand new hip or a knee, they have little simulators where they can simulate like 100 years of wear over the course of a year or so you can study stuff. And in the lab, when they made metal on metal hips, the wear rate was much lower than it is with either metal on plastic or ceramic on plastic. But the problem is the body doesn't like the wear if it's metal on metal. The body reacts to that, and so that's why people don't do that anymore. But people ask about what is metal on metal hip that I see at night. So now people don't do that. So I actually use ceramic for the head and plastic here. Some people use metal on plastic. I use ceramic because ceramic has a lower wear rate, so it wears slower than metal on plastic does. But anyway, and so that's how you do a hip replacement. Once you had joint replacement, then you come into the hospital. Most people stay about 2 days, okay? The most important thing after a joint replacement is just the therapy part of it. So getting up and getting moving, okay? Now, hips and knees are a little bit different as far as the rehab on it. The hip is basically just getting up and getting moving, okay? The knee, the most important thing is getting the motion back. So trying to get it all the way straight and bend it as far as it'll bend. In the operating room, when we do a knee replacement, like a lot of times when people come in before surgery, they can't straighten it out all the way. They can only bend about right there. Once we finish doing the surgery, you can get your knee out all the way straight, and usually we can get your heel where it can touch your butt back here, okay, which you probably haven't done in a long time. But we can do that. But then when you wake up after surgery, you can't do that right away because you've got a big dressing on there, you're sore and all that. But the goal is to get that motion back as quick as you can. And so what I always encourage people to do if they've had a knee replacement is every time their therapist works with them, ask them at the end of the therapy session, how straight is my knee and how much is my bend? And our goal on the knee is to be able to bend to 90 degrees by 4 weeks. Now most people are doing much more than that at 2 weeks, but your goal is 90 degrees by 4 weeks, and why is that? Because you need 90 degrees to do steps like this. So if you can only do 90 degrees or less, you do stairs one at a time like this. But to go upstairs like this, you need to have at least 90 degrees of bend to be able to do that successfully. And so that's why we encourage the range of motion exercises in therapy so much. With the hip, it's not as big of a deal. We still do a lot of therapy, but the main thing on that is just getting up, getting around, getting moving, because it's not as hard to get motion back in the hip as it is in the knee. After surgery, the nice thing about the hospital here is that you have 2 layers of kind of nursing care. You've got the regular nurse like you're all used to having, and then you've got Kim on top of it as well. So you're seeing your regular nurse throughout the day, and then she's coming usually twice a day to check on you to make sure you've got everything that you need, make sure everything's set up for home, in addition to case managers and things like that are getting everything approved by insurance. And she's actually done a lot of the work even before you come into the hospital to have everything ready to kind of for you afterwards. And so that's one thing that's nice about having Kim involved in the care. When you usually you're in the hospital about 2 days when you have a hip or a knee replacement. So for instance, if we do surgery on a Monday, then usually you're getting to go home on a Wednesday. We like to set you up if possible with kind of outpatient therapy. So going to a physical therapy close to your house, if you're able to get in if you've got somebody that can take you to the therapist. Why is that? With outpatient therapy, they've got all the machines and stuff like that that they can't really bring into your house. Now, if somebody lives by themselves or they are having a hard time kind of getting around, then sure, we will get therapy set up to come to the house. Occasionally, we have people go to inpatient rehab. That's more common if somebody's had, like I mentioned, like a hip fracture or something like that, where they're already having an issue with having a hard time getting around and they fell and broke something, then you're more likely to go to rehab. But for most joint replacements, we try to get therapy either close to where you live or have therapy come to your house if it's not possible to get to therapy. After surgery, we put you on a blood thinner for a couple of weeks just to decrease the risk of blood clots. Anytime you have an anesthetic and then having a surgery on your leg, you're at a little bit increased risk of blood clots, so we put you on a blood thinner. Knees are typically about 12 to 14 days of a blood thinner. Hips are typically about 5 weeks of blood thinner, just to decrease the risk of a blood clot, and it'd be very uncommon to have that if you're on the blood thinner. Some people are on blood thinners already, and so we kind of coordinate with your medical doctor or your cardiologist to pick out the one that would be best for you in that situation. And those are the main things about joint replacement. What are the things that have, I think, kind of made a difference over the past couple of years? I think, number one, there's medicine we actually give you in the operating room now that has significantly decreased the risk of needing a blood transfusion. We've had medicine that we've used for about 2 to 3 years where the chance of blood transfusion has probably gone down from 20% to 2% or less. So that's been good. I talked to you about how we test your nose to look for any bacteria before surgery. Studies show that if you find bacteria and you treat that before surgery, it decreases your infection rate by 50%. So all these things that we do kind of proactively to kind of have you have the best chance to have a good outcome and a good result.
Oh, what about the kidneys? You said you had to make sure the kidneys were...
Yeah, so if you decide to have a hip or a knee replacement, we call your family doctor or your cardiologist and make sure everything's okay from that standpoint. We check laboratory studies, like we check your white count to make sure you don't have any signs of infection. We check what's called a BMP, a test to make sure your potassium's okay for anesthesia. We check your kidney function to make sure that's as good as it can be. What we're looking for in that is something that's different. Like we have patients that we operate on that have kidney issues and kidney insufficiency, and that's fine, but what we don't want to see is, like, for instance, probably maybe about a year ago, we had a patient who had normal kidney function, and then we drew their preoperative labs, and their kidney function was not good. So we had to try to figure out, well, what's happened between last year and this year, because you wouldn't want to operate on somebody if we didn't know what was going on with their kidneys. We need to find out, is there a medicine they're taking that's making their kidneys not work well? Is there something else that we need to kind of investigate? So it's kind of, I think the whole part of getting ready for surgery is trying to figure out what the risks that patient will face and what you can do to minimize each one of those risks to increase the chance of having a good outcome.
What would you do just for a torn meniscus?
That's a good question. So what is a meniscus? A meniscus is something that's in your knee. You've got one on the inside and one on the outside. And if somebody's got a torn meniscus, their typical complaint is pain on one side of the joint, either the inside or the outside. And then it tends to be worse if you're like changing direction. So if you plant and rotate, like somebody calls your name and you turn around, and then all of a sudden it'll be worse. And then a lot of times you feel like it catches or pops inside the joint there. And so what you do for that, we would start just with the things we talked about before. A lot of times we'll try a cortisone shot. Now that's not going to heal the meniscus, but it may get the inflammation out of the joint. And if you don't have inflammation in the joint, it's not hurting, then we don't have to worry about necessarily going in and fixing that. Sometimes we'll do some therapy, because if you can get the muscle stronger in the leg, a lot of times it won't bother you as much. But ultimately, for a torn meniscus, you do a scope of the knee. And a scope is where you go to the operating room and we do an anesthetic, and we make a little poke hole right here in the front and right there on the outside, and put a camera in through one of the poke holes and little instruments through the other poke hole, and you remove the little piece of the meniscus that's torn. And so the way to think about it is, if you've got a torn piece of cartilage inside the knee, as you move your knee, it's catching and popping in there. So you can go in and remove that little piece that's torn to try to get rid of some of the catching and popping sort of symptoms. And that's a good question from the standpoint is, what's the difference between somebody that's got a little bit of arthritis and has got a torn meniscus, or somebody that's got a torn meniscus and a whole bunch of arthritis? So if somebody's got kind of bone-on-bone arthritis, if you got an MRI scan on their knee, they're almost certainly going to have a torn meniscus as well. And if you went in and scoped that person's knee, so you went in and cleaned out the tear, and they've got bone-on-bone arthritis, studies show it probably won't help them long-term. It might help for up to 6 months. That you'd be better if it's bone-on-bone arthritis to treat the knee with injections, anti-inflammatories, therapy, and then joint replacement. But if somebody's got a X-ray or MRI scan that shows the cartilage is good and it's just a torn meniscus, and their main complaint is catching and popping and locking and swelling, then those patients do well with the scope. And a scope is where we bring you in there, we put the camera in, we clean it out. The surgery takes about 30 minutes to do. You typically come in and go home the same day. And then just like with the knee replacement, it's important to do therapy to get your strength back. The recovery is a lot different though, because with a knee scope, we let you get up and walk that same day. If you were a college football player, they let you play in the ball game typically 2 to 4 weeks after surgery, so it's not a huge downtime. For instance, we did a knee scope on one of the people that works upstairs as a nurse in the OR, and we did their surgery on a Friday. They took off that next week to do their therapy, and that following Monday they were back in the OR helping us with patients and all that. So the recovery is a lot faster on that sort of thing. And so that's what a torn meniscus is.
Well, if you have just a torn meniscus and not a lot of arthritis,
right,
that would fix it.
So you can fix a torn meniscus, and then hopefully the pain would improve with that. Yeah, so you can. So you can go in and fix the torn meniscus, and if that's what's causing the pain, then the pain should improve after that. The key thing is kind of making sure everything makes sense. So like if somebody just came and they had an MRI scan and said they had a torn meniscus, well, you still want to make sure that you think that's the issue that's going on. Like if somebody comes into the office and they've got an MRI scan that shows they've torn their meniscus right here, then you can tell the patient they're probably going to do pretty well if they're tender right there. There's a little test we do where we twist the knee if it hurts right there. If they describe the pain as kind of a catching, kind of sharp, stabbing, kind of locking sort of pain, then that tends to do pretty well with arthroscopy.
I'm having a lot of swelling, but they can't do an MRI because I have a pacemaker.
Right. So 2 options in that case. So one, you would first start with all the conservative stuff first. If you can take anti-inflammatories, we do anti-inflammatories. If you can have an injection, we do an injection. You can do a CAT scan to look for that. A CAT scan is not quite as good as a MRI scan for showing a meniscus, but the new CAT scanner that they've got here actually can start to see meniscal tears and things like that. But a lot of times in that situation, you just go ahead and do an arthroscopy. So if somebody had pretty good joint space on their x-ray, we tried the other things and they hadn't worked. The test looked like it was a meniscal tear. It was tender in that area. You could get a CAT scan if you were concerned to rule out other things, but ultimately you would scope the knee is what you would do. Yes, ma'am.
Thank you.
Mm-hmm.
It won't fix the arthritis.
Right. Yeah, so and like she's saying, so the main thing with the scope is kind of getting rid of something mechanical that's gone wrong inside the knee. We can smooth out where there's worn cartilage, but you can't make new cartilage in that area if it's diffuse arthritis. It's a little bit different. Like if somebody's 18 and they have an injury that knocks off a piece of cartilage, there are things you can do to kind of correct that problem. But if it's a true arthritic thing where it's the whole knee that's kind of worn, then it won't help as much for that. But if somebody just has a torn meniscus and a little bit of early arthritis, and it's primarily a catching, popping, locking sort of thing, then that tends to help. Right. And why does your body swell? So your body swells because it's trying to make extra lubrication for the joint. So it knows if I put more lubrication in there, even if I got something torn, the knee might move easier. And the fluid in there is very slippery, so it's just kind of a lubricant for the joint, basically, and that's why your knee swells.
So if you have a joint replacement, shouldn't that get rid of the arthritis?
Yeah, so the arthritis is gone at that point. Yes, ma'am.
It is gone.
Yeah, so the joint is gone at that point. So at that point, the joint is metal and plastic. So I think one thing that sometimes people think is when you replace a knee, you replace the whole bone. All you're really doing is just the very end of the bones there. Now there are times that you do replace the whole bone. That's primarily in kids with bone cancer. You can go in and replace an entire femur, for instance, and replace that and do that. So you can do that, but the typical knee replacement is just doing just this. Yes, ma'am.
After you heal with a knee replacement, could I get back to riding my bike and hiking, or would I have to walk on a flat surface?
No. So that's our whole point, is to kind of get you doing those things. Because the nice thing about orthopedics is you're trying to allow people to continue to be active, and that's why I like doing orthopedics.
So I could walk up and down?
Mm-hmm. Yeah, that would be the goal, to do that, exactly. Because we have people that we see, patients in their 50s that, work. I've got a guy that's a mechanic that we replaced his knee, and he's working as a mechanic, doing fine. I've got people that work for AT&T that climb up and down utility poles and stuff like that we replace their hips or their knees. And they do fine as long as they don't fall off the pole. I've had that happen once, but yeah.
So that meniscus, is it made up of cartilage material?
Yeah, it's not the same cartilage that covers the surface of the joint, but it is it's a type of cartilage, basically. It's a way to think about it. The problem with the meniscus is that it doesn't have good blood flow to it. So if it tears, the body can't heal itself. Now, sometimes in people that have a sports injury, if they tear the very edge of the meniscus where there is some blood flow, you can fix that. But in most people, especially people, probably 35 and older, that's unlikely to be able to heal a torn meniscus. So you typically have to go in and take out the little piece that's torn. So back in the 70s, the early 70s, late 60s, before they had scopes, they had to make a big incision there and go in and remove the whole meniscus. Now we just do it through little poke holes.
So what do you actually repair it with?
You just remove the little piece that's torn. Well, so that's what you would do in somebody that had a torn meniscus. That's what we call on the outside of the meniscus there. And that's usually like a sports injury, somebody that's 18, 19, 20 years old. Most people that you see in their 40s and on up, it's a tear more towards the central part of the meniscus, and that part of the meniscus doesn't have blood flow to it. So what you're doing is you're just smoothing out the part that's torn so it doesn't catch in the joint. So the meniscus, if you think about it, they both look like little C. So they both look like C. So one's on the inside, one's on the outside. And what tears is the back part typically of the C. And so that catches inside the joint. So every time you move the joint, or if you're doing stairs, it'll catch in there. The way I like to think about it is when you're riding down the interstate and you've got an 18-wheel truck and they've got the mud flaps on the back, when the meniscus is torn, it's like that mud flap is kind of doing this. So when you're walking down your knee, that little piece is catching. And so you just want to get the little piece out that's catching inside the joint. If it continues, when should somebody have surgery for a torn meniscus? So the things are, if it's locking, so sometimes people have a big tear and the knee doesn't move, it's stuck. So you have to take that out to get the knee moving again. Pain is the other reason to do surgery. So if somebody has pain in that area that hasn't responded to the other treatments. And then the other thing is repetitive locking or catching episodes. So every time you're walking, if it's catching and popping, then that little piece of meniscus is kind of damaging the cartilage. over time. And so we try to go in and remove the little piece so it doesn't continue to damage the cartilage over time. Yes, sir.
Technology-wise, how are they linear with longevity? I had torn meniscus.
Right.
You went in, scoped it, looked like the inside part of my knee has no cartilage in it whatsoever. I referee soccer.
Yeah.
And my doctor said, you would just wear it out. I'd have to replace it again in about 3 years. He said, so just take it as long as you can.
Well,
I did 4 miles last night. So.
yeah. So, in my opinion, the whole reason to do something is to keep you doing those things, okay? Because if it's interfering with the quality of your life, that's when you think about doing something. If you look at studies show that 90% of knees are in working well 10 years down the road. It's hard to get longer data than that because people tend to move away and hard to follow over time. The different things that has happened over time, so the plastic that's in there, they've changed kind of the way that they make that, so that should theoretically last longer. I tell my patients to do what they want to do after knee replacement or hip replacement surgery. Is it better to kind of jog as opposed to run? Probably. But if it's something you enjoy doing, and that like if you came to a decision like I like reffing soccer and I'm going to have to quit because my knees bother me too much, then I would get it replaced and then see how you did afterwards. Let's say that over time that the plastic did wear, you can just take the plastic out and put a new piece of plastic in. That's it's something that we periodically do. It's not that common to have to do. And the other thing, just from a time issue, if you look at the way knees wear over time, they wear not based on time, but based on use. So I think that's kind of what you're referring to. But if you look at people, after they get to about 70, the number of steps people take each decade goes down significantly. So I like to tell people that we had a patient that had a hip replacement about 30 years ago, and they came in to see us. He was having a little bit of pain in his groin, so we x-rayed his hip and his socket. So this part of the hip had gotten loose like 30 years down the road. And so we talked to him and we said, well, how much trouble are you having? And he said, well, it hurts me when I walk. I said, how much walking are you doing? At that point, he was basically just staying inside his house. So it bothered him if he got up to walk, but it only bothered him for 2 or 3 minutes because that's as far as he would go. And so even though it was loose, and if he was 50 and worked in a factory, you might say we need to go back in and redo that. With him, we can just watch it until it started to interfere with the things that he wanted to do. So, if we did a knee replacement on you, I would let you go back to, ref and soccer when you wanted to. I think the most important thing for you after surgery would be just getting the muscle strength back, and just rehabbing as best as you could, and that's what I would do for a long-term thing. Because I think the whole point is to let you keep doing the things that you enjoy doing. If you're at the point where you can't do those or they hurt too much to do them, then we go ahead and do that. I've got a guy that is a caver, and that's what he loves doing, is getting in and out of caves with the Boy Scouts and stuff like that. And so, we have replaced his knee so he can keep doing that kind of stuff, and that's what he likes to do. So
I'm at the point that it just hurts to walk.
Yeah.
That's why I told my wife I'm going to come.
Yeah. So I think it'd be worthwhile to just think about doing it. I think going into it, I always tell my patients that as you're recovering from a knee replacement or hip replacement, you got to pretend like you're a professional athlete. Those guys have their surgery and they know they've got a couple months where they just got to work on getting better, and they're going to get like $5 million when they show up, after that. So you got to pretend you're a professional athlete, but you don't get the money at the end, But you just got to put your goal into just getting your strength and your motion back. And usually people that are well motivated are going to do fine with that. Yes, sir.
You do like a Steve Austin, make it bionic so I can run back.
That's right. That'll be good. That's good. That's right. Exactly. Yes, ma'am.
After 2 days in the hospital with a knee replacement, I'm going home. I live on 2 levels, but I want to get in the house, and my husband's not really physically able to hold me. Am I going to have trouble getting up the steps into my house?
So how many steps do you have to get into the house?
About 6.
Okay. So when somebody has that situation, is your bedroom on the main level?
I can stay on 1 level.
Perfect. Okay.
It's just getting into the house.
Yeah. So basically what we do before you go home is we have a therapist work with stairs with you.
Okay.
And like, let's say that it was the second day and you're having a little bit of trouble with the stairs, we just keep you an extra day and let you work on it one more time. If you had to go to rehab, you could, but usually what we'll do is say, well, let's just do one more day with therapy and see how you do that next day and then get you home after that. So we're used to kind of dealing with that. We want you to be able to get in and out of the house safely in case something were to happen inside the house where you had to get out quickly, So we wouldn't want to send you home if you couldn't do that.
Would there be trouble in the evening where the husband's on a CPAP and could not hear me or wake up for me to get to the restroom and back?
It shouldn't. You should be able to do that all before you go home. Yeah. So we want you up you go to the bathroom by yourself and stuff like that. We try not to even use like bedside commodes in the hospital because we want you getting up to go to the bathroom just like you normally would. Yeah, and the key thing, and that's good to ask all those kind of questions because, and that's stuff that you tell us like when we're in the hospital as well, so we know kind of what things you're concerned about, so that way we can address them and make sure everything's set up. The nice thing is that we've got Kim that works on that, and then there's also a case coordinator that's with us, and they kind of figure out what you need for the house, do you need a walker, do you need crutches, do you need a cane, make sure we get that ordered and approved through insurance and all that, so you've got all the things that you need.
If you have bedrooms and bath upstairs,
Mhm.
and you have about 14 steps,
Yeah.
is that a problem?
And she
So-
was alone.
Yeah, so sometimes what we'll do is sometimes we've even gotten like a hospital bed for the patient on the main floor, if they need to do that for a short period of time. So we've done that kind of stuff too if somebody needs that. Because then you probably have a bathroom on the main floor. And so sometimes we've had them bring in like a hospital bed.
Only
Yeah.
a half bath.
Yeah. So sometimes we do that. And sometimes some patients will go to rehab in that situation if they feel more comfortable.
I've heard that's hard, that if you're on Medicare, that they're not letting you go to.
We have to work on kind of getting it approved. Usually if somebody has an additional diagnosis that we can use, in addition to having the knee replacement, then we can get things like that approved. Kim's very good at working with that kind of stuff with the case coordinators. And what I'll recommend if somebody's thinking they might want to end up going to rehab afterwards is before you have surgery to go around and pick out which one you like. And that way you can see them and tour them and all that kind of stuff. And then once you know your surgery date, call the place and say, hey, my surgery is on Monday. I should be getting out on Wednesday. Or sometimes with rehab you have to stay an extra day. Some insurance companies require 3 days. But then to call them and say, hey, I should be getting out on this date, just make sure, and they'll come by and see you in the hospital and help get all that approved as well. Yeah, but there are different things we can do. We can get a hospital bed on the main floor. It's one thing that we do. I think, as far as going up and down stairs, most people should be able to do that within 2 weeks to do a flight of stairs.
Within 2 weeks.
Mm-hmm. And a lot of it's just what your previous balance is and all that. I mean, we've got some people that would do that, the 2 days after surgery. But if somebody's got, a little bit harder balance and things like that, or a little bit of weakness because they hadn't been able to get around because their knee's been bothering, then it could be up to 2 weeks. I mean, some people can do it kind of right away after surgery, but I think, most people should be able to do it by 2 weeks at that point.
Would balance problems be an additional diagnosis that might help qualify you for some rehab?
I would have to ask kind of the case manager people. A lot of it goes into like, does somebody have heart trouble? Do they have some lung trouble? Just things like that. Do they have something else that they need to kind of keep an eye on? It's a little bit easier to get people with hip issues and knee issues to rehab for some reason, but.
Can you address some of the alternatives to surgery?
Yeah. So,
Like they keep advertising stem cell therapy.
yeah, so the Orthopedic Academy kind of looked at all that kind of stuff, and they don't have anything that has been shown to significantly change anything at this point, and that's why those things aren't covered by insurance because it's still considered experimental. Just from a personal standpoint, if you when you hear ads on the radio where they're just going to inject something into your knee, I mean the chance of that going right to where it needs to go and solve the issue seems to be unlikely to be effective because. For instance, in surgery, when we do a scope on somebody's knee, like let's say that we were going in and scoping somebody's knee for the meniscal tear, sometimes we'll see a little piece where it may be about the size of your fingernail where a piece of cartilage is just kind of gone and missing in that area. So we can take a little probe and make an opening into the bone in that area, and that stimulates the stem cells to come out and form a patch over that area that can form some fibrocartilage in that area. But if you do that, you're supposed to protect the patient and have them be touchdown weight bearing for 6 weeks and do range of motion to the knee. So you're stimulating stem cells, but when you do that, but you think about how we protect it. We have them touchdown weight bearing, we have them do knee range of motion type stuff. And so we're real careful with it. So I think the chance that somebody could inject something into the knee and then have it go right to where it needs to go and stimulate cartilage growth in there is probably, if you wanted to try it, you could. I probably wouldn't spend a ton of money to do it unless I just had a lot of extra money to try,
What about Cooley?
Sorry?
Cooley, is that the way you pronounce it?
So you're talking about just where they basically go in and they do cold treatment for nerves and stuff like that. So basically what you're doing with that is just getting it where your brain or your spinal cord can't feel what's going on inside the knee. So that's what that's doing. It's kind of like deadening a nerve for a period of time.
So, a while ago you were talking about the pain that radiates down your leg from the hip.
From the back, yeah.
Okay, so if it's hip versus back,
Right.
What's the difference?
All right, so that's a good question. So when it's coming from the back, usually it's pain that starts kind of in the butt cheek and then goes down into the leg, okay? When it's the hip joint itself, it's usually in the front or off to the side over there. But I mean, we run into situations where somebody has both of those things, okay? So if somebody has an arthritic hip and they've got a herniated disc in their back, how do we figure out what to address first? Well, sometimes the patient will tell you, they'll go like, well, most of my pain's right here, most of my pain's right here, and you can do that. During an examination, one of the things we do is when you're on the exam table, we bend your hip up and rotate it in. That's putting stress on the hip. If that causes your pain, if we say, is that the pain you're here for today? And they go, yes, and it's the hip primarily. If it's from the back, a lot of times when you're on the exam table, we just lift your legs straight up. And if that causes a pain, then we know it's coming from the back. But then also sometimes we'll do injections. So occasionally we bring you to the procedure center and we start an IV, we give you some medicine to help you relax. And let's say you had a herniated disc in your back, well, we can inject cortisone directly where the disc is herniated. And we inject cortisone and numbing medicine in that area, like people talk about an epidural block or what we call a selective nerve root block. So if we do that injection and all your pain goes away, if it only goes away for several hours, then we know that the back is your primary issue. If we do that and you go like, man, my butt was a little bit better, but this down here still hurt me, that was my biggest problem, then we know it's primarily the hip. And also we can inject the hip as well. So, if somebody comes in to the office and they have an arthritic knee, we can inject that in the office because we can feel that. If somebody has bursitis, like you were talking about the trochanter, we can inject that in the office. But if somebody has true hip arthritis, we can bring you to the procedure center, we can start an IV, give you sedation, and numb that area up and inject cortisone into the hip joint. You need an x-ray machine to do that. So if we did that injection and your pain improved, then we know it's the hip that's causing the issue.
Is that for a long term?
It's not long term. It'd be just like with the knee, where it might help you for several months, but not permanently when you're injecting the hip.
You're going to have to probably do something.
Probably, but sometimes we end up doing that. For instance, we have patients that their cardiologist says they cannot have surgery. Like I've got a lady, she's 90 years old. Cardiologist says she cannot have surgery, and several times a year we'll inject her hip just to help get her pain, and that helps her for 2 or 3 months, and her son brings her back to the office and we set her up for another injection. So we do that. You ask about, can it help long term? The ones from the back, if somebody has a herniated disc in their back, studies show that if somebody wants to have surgery for their back and a doctor thinks they need an operation, half of people will cancel back surgery after getting 1, 2, or 3 blocks. So there are, there are ways.
Excuse me.
Yeah, both of you. Why don't you do yours and we'll do yours?
I'm sorry.
Yeah.
What's the time between the injections?
So used to they would do 1 injection every 2 weeks for a total of 3 injections. Now most people do. I do the injections as well. But now what we do is do an injection, see how you do, because you can have 3 over the course of a year. So if you get 1 in January, there's no reason to do 1 2 weeks later if you're feeling okay. I'll just have you call me. If you started bothering you again in the summer, we do 1 in the summer, then do another one at Christmas. So you can spread them out over the course of the year. And then what was your question?
See how often. That's what
Yeah, exactly. Yeah.
The same thing.
Right.
'Cause I've had 2 and they hadn't done anything.
Right. So, if you've had 2 blocks and neither one of them has helped, as long as and you've had an MRI scan that shows that they're doing the block at the area of concern, then at that point you'd have to decide, how much is your pain, if it's something you can live with or not. If it's something you can't live with, then we would look at your MRI scan or your CT if you can't have an MRI, and then talk about whether or not surgery might be beneficial for you.
Yeah, I had one, but it was like degenerative.
Right.
Spine.
Mm-hmm.
But I've had 2 blocks.
Mhm.
Neither one of them did anything. I've had recently a Burside shot.
In your hip.
Yes,
Okay. Yes, ma'am.
But
Did
it
you have
helped a
hip
lot.
replacement?
No.
Not
mm-mm.
yet.
But most of mine in my spine.
Yeah. And so at that point, you would look at your MRI scan, see what it shows, and if the blocks were done kind of where they needed to be and they didn't help, then you would think about doing surgery for it to take pressure off the nerves. The way to think about it, if you ever hit your funny bone, it causes pain to go down into your arm. That's the same thing with the back. So if you've got pressure on the nerves in your back, you feel that burning pain that kind of goes down into your leg. Now, usually, like with the back, if you've got a lot of pain in your butt cheeks and your thighs, it's worse when you walk, and it gets better if you go to the store and you get a shopping cart like that and you lean forward, then that's usually spinal stenosis, okay? And those patients do pretty well with that. You go in with surgery and you make a little incision on the back and you just remove some of the bone to take pressure off of the nerve so the nerves don't have as much pressure. And the way to think about it, the bone we remove is like that wall there. It's not holding up the building, it's just a separation. So you just remove the part of the bone that's just kind of a protective area for the nerves, and you don't take the big structural part of the bone out. Yeah.
And a doctor can determine what to remove and what not?
Yeah, you can see there. You're trained.
That sort of thing.
That, and then also just, so you look at the MRI scan and see where the level is. Blocks are helpful because what you'll find, it's a little bit different if you see people that are 25 or 30 and they have a disc herniation. Usually the rest of their back's fairly normal. When you get people that are 60 and older, a lot of times there are multiple levels that are involved. So sometimes doing a block at first is useful because, let's say somebody's got 3 or 4 bulging discs or herniated disc, and you inject cortisone around the one you think's the worst, and then that gets rid of the pain. Then if you go in at that one level and fix that level, that there's about an 85% chance that you'll feel like you did when the block was working. So in other words, if somebody's got discs that are worn out all through their spine, part of it's trying to figure out which one is causing the trouble and addressing that. So that way you have the least amount of surgery and the easiest recovery by knowing exactly kind of where to focus your attention to.
And the hyaluronic acid you were talking about a while ago, can you do supplements?
So you can take supplements and things like that. One of the hard things about, we have people take glucosamine, chondroitin, and things like that. Part of the hard thing on supplements is that it's hard to know for sure how effective they are, just because to get it approved to sell, if they label it a supplement, they don't have to prove that it works. They just have to prove that it doesn't cause harm. So I'll tell people things with that is to try it for a month, see if it helps you. If it helps you, great. Always let your doctor know if you're taking a supplement, if you're getting ready to have surgery, because some of those can lead to increased risk of bleeding and stuff like that. And so usually people will stop those a little bit ahead of time. One thing to think about is, some of the supplements, like you see people advertise, they got this sort of thing you can take and it makes new cartilage. That's unlikely to be effective. If you think about it, it's got to go through your GI tract where it's going to get digested and things like that. Also, if you watch some of the late night commercials on TV, they'll show x-rays that things change. Well, you can make the x-ray look different by whether or not you take the x-ray with the patient standing or laying down. So you can have the patient laying down and look like there's cartilage and they stand up and there's no cartilage there. So you could show the weight-bearing view to start with and show a non-weight-bearing view and then make it look different by that. And sometimes the x-rays are upside down on the board that they're showing, you can see.
What about those places that advertise coming into their laser center and you'll be up and walking?
That's with the spine stuff. You can try some of that. Most of that stuff though can be done in Birmingham through small incisions and things like that, so they can do that. It depends on kind of what you need. For instance, if somebody's got a degenerative spine where there's multiple levels of involvement, there's not really anything you can do through a small incision to do that because you've got to go in and decompress all the nerves. Could you make a bunch of small incisions? Probably, but it wouldn't be that much of a difference. If somebody just has a herniated disc, and you can in Birmingham get somebody to make an inch incision, go in and just take the little piece of disc out. You can do it through little tubes and things like that. So that all can be done. You can send stuff off. One of the problems with having stuff sent off is that that they don't take a lot of different insurances, okay? So they're more interested in certain types of insurance. And then the other thing is if you have a problem, then it's a long way back to find those people, Yeah.
So do you do posterior or anterior?
I do posterior approach. That's kind of where I trained.
Posterior?
Yeah, I do posterior approach, yeah. And, the difference is between anterior and posterior is, with posterior, people are worried about dislocation and things like that. It's very unusual to have a dislocation when you do a capsular repair. In the operating room, when we do surgery, we actually we do all the things we tell you not to do, and if it causes any sort of instability, then we correct something at that time. Anterior approach is, the downside of anterior approach, there's higher risk of fracture during surgery. So it's just different sort of things. And what I tell people to do is pick their surgeon and then let them do what they're comfortable doing. People ask about, well, this implant, that implant, all this kind of stuff. It's kind of like when you get on the airplane, like let the pilot fly the plane and let him do that, what he's comfortable doing, instead of trying to introduce a bunch of extraneous variables in there. Could we do anterior approach? Sure. Where we train, we did all posterior. And the way I sort of think about it too, is kind of what you want is you want individualized care to you, but you want it in a setting where it's routine. So everything kind of goes through the same thing, so everybody's as comfortable as they can be during the time that they're doing surgery.
So what do you say for a hip replacement would be like the recovery mark?
Yeah, so each person's different. Obviously, it's different if somebody's 45 years old and if they're 80, obviously. But our goal is you have a hip replacement. You're up walking the day after surgery. You're going home the next day. Hopefully, get you off of a walker or crutches onto a cane at 2 weeks, and hopefully, off the cane subsequently after that. We did a hip replacement on a gentleman. He came in and saw me, and he had just left one job to start another job. And so he had set up his own business. And so then all of a sudden he got to the point where he just couldn't walk. And so we had to do a hip replacement on him. So he said, I got to go back to work just right away. And so, we did his hip replacement. A week later he went back to work. He was kind of like an investment sort of person. And so he could at least go in for, 4 hours in the morning, talk to his clients, call them, make sure everything was going okay, and then he went home, took a nap, and then go do therapy in the afternoon, and then go back the next day. So, I think you can get up and get active. A lot of it's kind of what you want to do, and kind of how eager you are to do it, and that kind of stuff.
So probably at 6 months.
Oh yeah,
You should be.
Yeah, 3 months really.
3
Yeah,
months.
yeah. So, usually when people are coming in with hip replacement 6 weeks, they're doing really well. I usually tell people, the first 2 weeks you kind of wonder why you had surgery. What was I thinking? And then usually once you get through 2 weeks, you're like, okay. And then usually at 6 weeks, you're glad you had it done. It's kind of interesting. We had a lady a couple years ago, and she was probably about 80. She had bilateral hip arthritis, and we replaced her hip, and she's getting ready to go home at that point people say 3 days, now they say 2. She said, can we just stay in here and we do my other hip, because this one's feeling good? And I said, well, you need to make sure you get your blood count back up and recover and all that kind of stuff. And so, some people are like that. And then the other interesting thing is you see it more commonly in knees where people have both knees. You do one and we'll see them back. And we'll do the other one as soon as 4 to 6 weeks down the road. We like you to get a chance for your blood count to build back up, okay, and your body just to recover from having a surgery. But some people, if you replace one, even though the other one's worn out, they go that's my good knee, so my other one doesn't hurt me as much. I'm putting all my pressure on my good knee now. And so a lot of times that you run into a situation where that you fix one thing and then that lets them get around, so they even delay doing the other one. And other people are like, well, this is doing so well, I want to go ahead and do my other one.
Well, so with the hip replacement, what is that limp?
So with the limp, the key thing is getting that, like you're talking about the trochanter, is getting that muscle stronger up in this area again.
And that can be done through side kicks and things like
Just
that?
therapy, yeah, just a routine therapy with time. Yes, sir.
I was just going to say, I had my knee replaced. She was talking about
Mhm.
recovery time. And what I did before I had it replaced, I took about 2.5, 3 months in a swimming pool to
Oh,
make sure both legs, were as strong as they could be. Okay, I had my knee replaced, not hip knee. And I was off the crutches in 6 days and had a full bend within 2 weeks.
wow.
Don't tell him that I took the surgery for 4 weeks. So
That's good.
And also, I distance. And when the knee got replaced, pain in my hip left.
So Kim would give us a sheet with exercises, pre-op exercises.
Yes, ma'am.
And I've been trying to do this
Yeah.
on my own
Yeah.
from where I researched, Googled them.
Right.
But she has copies of
Right.
something that we could get, right?
Now,
Yeah.
are you just here at this Brookwood?
Yes, ma'am. We have another one that just started at Brookwood, actually, Brookwood.
So there's
there
someone
there is a
over there?
there's a joint navigator over there, and she's
Well,
been here
I'm
about
sorry,
6
what's it
months.
called, joint navigator?
Navigator. Yeah, it's just a resource person. So, I will say one thing, a lot of my patients will tell other patients, a lot of this is attitude. If you want to get better, you're going to get better. I mean, you know, some people don't, but most people, 98% of people do get better with the attitude. And another thing that I will mention is a lot of people are scared of the pain of this surgery. They've heard all these dramatized things that knee replacement's the worst surgery ever, and oh, my grandfather's sister's mother had it and she can't walk again. No, the pain that you're having right now is so bad that that's why you're here. And the pain that you have after Johnson or whoever fixes it is temporary. It's temporary. Like he says, they'll wonder, why did I have this done 2 days later, 3 days later? I wish I could take it back. But give you a couple of weeks and it's all better. The pain is from surgery's gone, the pain from, you know, just wear and tear over time is gone.
Yeah.
So we fixed that.
The people that have the most trouble with pain afterwards are people that are taking pain medicines before they have surgery. Because what happens is your body makes more receptors, so you tend to have more pain afterwards. And so that's when it gets to be hard. So if you get to the point where you're starting to think, I need to take pain medicine for my joints, then that's when you probably ought to think of having it done. Because that's what makes the recovery hardest. I mean, that's what we see in
Is the pain medication?
the preoperative pain, people that are on preoperative narcotic pain medicines.
Preoperative?
Yeah, like people that are taking Norco or Percocet, things like that before surgery, that's what makes it harder to recover afterwards, just because your body built up a tolerance to the medicine. And so it's a little bit harder to recover from. Yeah. Yeah, so that's why it makes it a little harder.
Medication to get you at where
Right.
somebody who does not
So what
take
is better, just not to take the pain medication?
Yeah,
If you can,
yeah,
yes.
exactly.
And just go.
Some people
without
can't,
ibuprofen
some people
or-
can't
Right.
tolerate that. Some people do have to take the pain medication.
Right.
And it's okay, but then they'll try to back off as we get better.
That makes sense.
Yeah.
Too, even if you have some semblance of residual pain,
hmm
it's usually still 1,000%.
Yeah, most people do very well.
You had
Oh,
the
yeah,
surgery,
that's true.
Yeah.
but you're still grateful,
All right.
'cause
What is robotic surgery?
So what is robotic surgery? So robotic surgery is just using something else to kind of gauge what your landmarks are. So in surgery, you have to reference everything off of kind of normal anatomy, okay? So you can use robotics to try to help with that. The issue with robotic surgery is like anything. It's kind of picking what you're comfortable with. So like when we train, we train to look at all the different landmarks and how you do your surgery and all that kind of stuff. And that's why we try to make it pretty reproducible where it's the same every time. You can use stuff to reference where a computer will tell you what the rotation is and things like that. The problem with that is though you have to make sure that the stuff you're using to reference is correct. So in other words, it's kind of like if somebody's flying an airplane. If the instruments are confusing, it can cause problems. So the same thing if one of the dials if the reference is not set up right, it can cause a problem. When I actually did a fellowship in hip and knee replacement, and so we did some of the studies on the early referencing and stuff like that. And their main thought of making that was to try to help people that didn't do a lot of joint replacements. The problem is that you might believe the referencing more than what you're actually seeing, so you can make an error from that way. So just because it's navigated doesn't necessarily mean that it's any different. It's what you're using to kind of judge your landmarks on.
So is it better not to have that?
No, I just would let your surgeon pick what they're comfortable with. The key thing is pick the person you want to do the surgery and let them do how they feel comfortable doing it.
I just heard that sometimes people do better with robotic.
I don't know of any study that shows somebody does better or not better. I think it's pick who you want to do the surgery and let them do the way they feel that it can be done. Because the whole thing is just kind of referencing how you reference everything off of. And then I think the studies that we were doing were showing that it might help somebody if they didn't do a lot of joint replacements. But if somebody does a lot of joint replacements, I don't think it would make a huge difference one way or the other. downsides to doing navigation as well. There's added time in the OR. There's added expense of doing it and things like that. I do all my. I don't use navigation when I do it. I reference off your natural anatomy. We draw. It's really technical, but we draw your what's called the transepicondylar axis. We do an axis 90 degrees off the long axis of your tibia. We check it multiple different ways and look at that. And then once we do like a knee replacement and a hip, same thing, we put temporary components in and make sure everything looks like it works well before we put the actual ones in. That's a good question. All right, you want to do your part?
If
All right.
you have to suffer before you get a surgery, when you say about the medicine.
Yeah, well, I think.
You take medicine before.
Yeah.
Usually they try to get, well, I had rheumatologists at
Right.
Brookwood for over.
No, right. And rheumatologists have to help you with that sometimes.
That's what I'm saying. If they give you medicine and then you decide to have the surgery, that means you're gonna suffer more.
Well, we just have to know that going in.
We just
Yeah.
have to adjust it.
Yeah.
I mean, because you're used to it. Like
Yeah.
if you take 3 Norco a day, you're probably going to need 6 or
You know.
7 to get it under control at first. Yeah.
So and the main thing is just if you're in that situation that you just have to remember after surgery that you just kind of fight through the pain to get your motion back, because you only have with the knee replacement about 4 to 6 weeks to get your motion back. After that, you kind of got what you've got. So you just got to realize, hey, I just got to get through this next 4 weeks to really get my motion back, and just pretend, like I said, you got to pretend like you're a professional athlete and you're just going to work through everything. And you can do it. And the thing is, the nice thing is the key thing to remember is you're not doing it by yourself, okay? You got the nurses on the floor, you got Kim, you got the doctors, you got your family and the therapist, and so a whole bunch of different people all on one team trying to get you better.
Determination.
Yeah. Yes, sir.
Perseverance.
Replacement, how long would you expect to be out of work?
So if you have like a desk type job, then most people get back to work at 2 weeks. Now, if somebody has short-term disability insurance, then obviously they can stay out, as long as they need to, they want to, on that standpoint. But I mean, desk type job usually 2 weeks. If somebody works for like AT&T and they're climbing poles, that's probably 3 months, on that. Most people with regular jobs, a desk job 2 weeks, regular jobs probably 4 to 6 weeks. If you worked in a department store, probably 6 to 8 weeks if you're on your feet all day working in a Walmart or somewhere like that. Yes, ma'am.
One final question. You
Yes,
said
ma'am.
usually for knee, local anesthesiologist. But
So
people like me who have some anxiety about.
So good question. So with the knee, we do a block before surgery to decrease the pain. But then you either get a general or a spinal, either one. Same thing for the hip, either general or spinal. It doesn't matter to the doctor which one you do. It's up to you and the anesthesia doctor. But if you get a spinal, they give you enough medicine that you don't know that you're awake. The difference is you're breathing on your own, so you don't have a breathing tube in. The one nice thing about a spinal, as long as you don't have a lot of arthritis in your back, is that your whole lower half is numb, after surgery for 6 hours or so, which is good.
And if you're on a blood thinner preoperatively,
Yeah.
they can't usually do a spinal.
Right.
But we do
Right,
recommend a spinal.
right. Yeah, and then,
And a block.
right. And what I tell, patients too is kind of, talk to the anesthesiologist before surgery, and kind of whichever way they're leading you to go, then I would go down that path, because that's kind of what they feel comfortable doing. And usually it's a spinal, like she said, in most cases.
It gives you a chance because you're numb when you wake up, and then you can start with your
Right.
pain medication
Right.
while it's waking up.
Right, and then usually when we're doing this, if we're doing surgery and you've got a spinal, usually we hear you snoring. Okay, you're not talking to us or anything like that. Now, if we shook you, you'd wake up and say, "Hey, how are you doing?" "Oh, I'm doing okay." Then you usually just fall right back to sleep. So it's not like you're awake talking to us or watching the thing on TV or anything.
You do shoulders too?
I do shoulder scopes and things like that, and one of my partners does a lot of those as well. And so we'll work on those together sometimes.
How long do you have to be off the blood thinner before you can have surgery?
Depends on what blood thinner, so we call your cardiologist and we find out exactly what they say. So each one, it used to be an easy answer, but now there's like 10 different blood thinners. Each one has a different number of times. So usually it's somewhere between 2 and 7 days, depending on the blood thinner. But we always go by what the cardiologist says on that.
But I should go ahead and see my kidney specialist before I
Not necessarily. Just kind of see the doctor who's going to do the surgery and let them look through everything and see. And then what happens is, like for instance, usually we'll get the medical doctor to look through everything and they check the labs. And if your labs look good, he might say, well, you don't, or he or she might say you don't need to go see the kidney specialist. You know, if everything's pretty much baseline. Now, if somebody is on dialysis or something like that, then yeah, they probably got to see their kidney doctor ahead of time.
My injury was 6 months ago.
Mm-hmm.
And would wearing any kind of knee brace help me down the pain?
Knee braces can help some. I wouldn't spend a ton of money on them. Usually what I tell people to do is go to Walmart or CVS and just get one of the $25 braces that has the little cutout in the front, the Velcro straps, and to try that. I mean, we can get fancy braces, but I usually just say try something like that to see if it would work. The problem is they do make braces that you can use for knee arthritis. Like if somebody's got bone on the inside of the knee, you can actually get what's called a medial unloader brace to try to push here and there and to jack the knee open. But the problem is, if you think about it, how hard would that have to push? It has to push pretty hard. So the brace is uncomfortable to wear, that type of brace, and so people usually wear them 3, 4, 5 days and they don't wear them anymore. They do that more commonly at the VA because it's so hard to get knee replacement approved that they'll just have people wear braces for a long time. But I usually just have people get one of the inexpensive braces from Walmart or CVS and try that.
I will try that.
Yeah. Mm-hmm.
I have one of those.
Yes, sir.
For my knee.
Yeah.
It's wonderful.
Yeah, exactly. So we'll have people do that. It helps, especially if you're going up and down stairs and things like that, that sort of stuff.
Weird thing it does though is it redirects the muscles in your calf, so after you wear it, other part of your muscle.
You're a little bit crooked. All right. Well, I'm going to leave some cards up here. If you need anything, feel free to give me a holler, and Kim's going to talk about the rehab afterwards.
Thank you.
Yes, ma'am. Y'all have a good day. Thank you, guys.